As you'll see from my next slide, there's very little respiratory virus around, which is why I've reduced this to just this one slide. You can see that flu is still dropping rapidly. Flu is clearly fine. RSV, the other thing we're worried about, also peaked and is fine. COVID, maybe it's drifting up a little bit, but nothing like the big peaks that were going on last year. So COVID seems to be pretty much under control at the moment. This long period of no peaks is starting to get quite encouraging. That it's sort of declining into just a native infection that we're all getting from time to time. The rhinovirus is common cold, basically. Everyone's probably had that in the last year or so, and that just jogs along at more or less a steady level throughout the year. This is covering last May all the way through till this April. And you can see that seems pretty steady. I have a feeling that's what COVID is going to be like, though hopefully at lower levels. So nothing to worry about there, no peaks, everything's declining, we are doing just fine. I think I've got a couple, I just thought I'd mention other things that people have been concerned about over the winter was the measles. Every year we worry about the measles. Mostly now because of the lack of children getting immunisations, and you can see that worry has declined quite nicely as well. We're almost at 0 cases. What's that? About 2 cases at the moment in a day, I would imagine. So that's also low. And if anyone can remember the Mpox sort of scare story, I think it was last summer, going into autumn, called monkeypox, which is shortened to Mpox because people didn't like to use the word monkey. And that's almost gone. It's never expanded into the big infection wave that was threatened at one time. This thing came out of Africa. There were 2 or 3 groups called clades, and they thought that one of them would be a potential threat in the UK. So they monitor it, and the monitoring has shown over the last year really nothing's going on. Tiny numbers, maybe 1 or 2 cases in the average month. So there's nothing to worry about there either. Just sort of set your minds at rest. Okay, that's it for respiratory viruses this time. I asked for questions in the Facebook group. I'm not sure if I did in the Telegram group, just to see if there's anything people wanted me to talk about today in particular, and I got 3 replies, so we'll just cover those, and then have a talk about the clinical trial that we're thinking of doing, which should fill up an hour at least. So, your questions. Every month I would be quite happy to answer any questions you come up with in a more extended talk like this. It gives us an interesting topic to talk about and discuss. I do it from time to time, but I'd like to do it if I can remember to prepare beforehand on a monthly basis if there are questions coming up. I'm currently, I'll tell you about that later. I'm currently answering a lot of questions on aspergillosis.org with the help of AI, which has been really, really useful. So we'll talk about that in a bit. So this question number 1, lung disease and voice issues, why lung disease affects your voice. Okay, so why is it that people who have aspergillosis and other lung diseases tend to have their voice altered to become quite soft, can become quite hoarse? Why is that? And there's a whole range of reasons for this. Side effects of any medications you have, I think most of this group will have been on corticosteroids at some point. If you've got asthma, then you're likely to have been on inhaled corticosteroids. So the steroid is being inhaled directly into your voice box, essentially. And because of the things that drug does, It can change the texture of the tissue around your voice box, and that can cause hoarseness. It can also cause fungal infections, usually a yeast infection, thrush in your throat. And both of those things can affect your voice quite a lot. So that's one reason why your voice may be affected. I think the person asking must have had a particular situation in mind, but they didn't say, and we're recording this, so I'll just replay all of this to everybody, and hopefully the person will find something that relates to what they were asking about. Upper airways, this is all the airways above the junction that goes into your lungs, up from your mouth to the top of your lungs. Diseases like chronic aspergillosis or sinusitis, because an infection in your sinuses is essentially a disease of your upper airway, because your sinuses are continuous with your throat. Those inflammations can affect the sinuses, and once your sinus, it's a bit like pinching your nose. That completely changes the resonance and tone of the voice. Hello? Okay. Fatigue and low oxygen levels. People with advanced lung disease may experience general fatigue or hypoxia. So this is if you're quite bad with lung infection, and that can make your speech slower because you haven't got the energy to speak quickly, quieter, or even less clear. So that's another factor. I think there's more. Yes. That's a repeat of the last lot. Okay, so we'll go on to the common symptoms. And the common symptoms are hoarseness, or you can have a weak or breathy voice. You can have trouble projecting your voice, although some of us have that normally anyway. Vocal fatigue, especially when talking for long periods, as I'm going to find out later. Or dry throat and frequent throat clearing. We'll cover a bit more shortly.
Can I just, Graham? Can I just say?
Yeah.
I had problems with my voice over the years, and it was mostly down to coughing.
Yes.
If you cough a lot, it affects your voice.
Yes, I think that was on the list on the second slide that we didn't get. When is it a problem? When you have to have it investigated further? If voice changes last longer than 2 to 3 weeks, it starts to become of interest. If there is pain, difficulty swallowing, or persistent coughing, it could be an issue. Of course, these could indicate other things going on in your throat that need checking out. If you're on inhaled steroids and voice changes are new, someone who's asthmatic will have been on inhaled steroids probably most of their life. But if something happens that's new, then that's a significant finding, and you need to report it to your doctor. And also, if you have symptoms like breathlessness, chest discomfort, or chronic infection, that might indicate something else is going on and it needs further investigation. So any of those things, don't ignore it. Go to your doctor and point out that there's been a change and it might need looking at. Okay, evidence-based tips for protecting your voice if you have a lung condition, especially one involving chronic cough, inhalers, or reduced breath support. So, simple stuff, simple non-medical stuff. Hydrate well. Drink plenty of water. Now, 6 to 8 glasses a day. It seems a bit vague. I don't know what they would call a glass, so I presume maybe half a pint. So maybe 3 to 4 pints, maybe 1 or 2 litres a day will keep your vocal cords and mucous membranes moist, and everything will be operating normally. It could be that the atmosphere at home, and right now I've noticed the relative humidity indoors here is well below 30 because we've not had rain for a long time, and the temperature has risen here. It's gone up to 33 today because it's a bit cooler. When that happens, you can start drying out your throat and causing problems. So you could use a humidifier to increase the level of moisture in your home, in the air at home, but of course don't overdo that because too much moisture can encourage molds. So if you're going to use a humidifier, we'd probably use it in combination with a relative humidity meter, just so that you're not going over the top. Use your inhalers correctly. That's not as easy as it sounds. There's a whole bunch of videos on the BLF website showing you how to use inhalers correctly. And technique can always be brushed up and improved. Rinse your mouth out and gargle after using steroid inhalers to stop that powder staying at the back of your throat and causing problems with infection. Use the spacer, which kind of dilutes out, as you would know, the amount of steroid going in at one time, so more of it goes down your lungs where it's supposed to go, and less of it sits at the back of your throat to potentially cause problems with either direct problems from steroids affecting your vocal cords, or indirect if the steroid causes an infection. Report persistent hoarseness or throat discomfort to your doctor. Avoid throat strains, so when you're short of breath, pause, think about it before you speak, because it's possible to strain your voice and damage it. Avoid whispering. This is a new one on me. If you actually try to whisper, it can strain your voice as well, more than gentle talking. So I can sort of understand that, but I've never really thought about it. So whispering isn't particularly good for your voice, so try and avoid that if you're having problems. And warm up your voice with gentle humming. It's not as if you're about to give a singing performance, but if you've been quiet for a while, and quite often I sit in my desk all morning and not talk to anyone because there's nobody around, and then someone asks me a question, my voice can be a little bit strange until I've had a cough and warmed it up a bit, so that can be helpful. Managing coughing and throat clearing. Chronic cough and throat clearing can traumatise the vocal cords. I think most of us could understand that. Anyone who's had a cough for a while will find their throat getting quite sore. Try silent swallowing or sipping water instead of throat clearing, which is an interesting one. I don't know how many of us can actually manage that. I will certainly try the next time that I'm clearing my throat. I've had a respiratory infection since New Year, so maybe I can try that when I get the next one. Consider a speech therapist referral. That can be surprisingly useful, and they can identify some quite unusual phenomena. I think we had a talk a few months ago from someone who worked in the cough clinic about that kind of thing. Optimize breathing support, so it's sort of techniques. Speak on the breath, not after it. So yeah, okay, I kind of understand what that means. Use short phrases and rest between sentences if breathless. I think you would be more or less forced to do that if you were breathless. Pulmonary rehab or physio can help. Physios can always, often can help and often get ignored. So they can a good respiratory physio can probably help a lot more than you think. And you can ask your doctor when you come to clinic here if you can see Phil, if you think he can help, because that's his job. Obviously, reduce irritants, things like smoking, other people smoking in the room, heavily scented products, which are very popular, scented candles, things you plug in that give out perfumes, especially if you've got something like aspergillosis or asthma. All of these things can be very irritant to people who have sensitive airways. Try to avoid these, don't plug these things in, and stay clear of smoking. Caffeine and alcohol can dry the throat, where's the fun left in life if you're cutting out everything? But anyway, limit caffeine and alcohol, as it can dry the throat, and avoid shouting or speaking over loud noise, which seems really reasonably obvious. Last one, seek help. If your voice is hoarse, weak or breathy for more than 2 weeks, get a referral to ENT or speech language therapy. The changes may be due to a vocal cord dysfunction, infection, or effects of medication, so it's worthwhile engaging someone to help you work out which of those things is causing the problem and stopping it. Okay, that was the first question. The second question asked by a patient is, as a patient, what formality routes, I presume they mean formal routes, must consultants take to assess any patients with aspergillosis suspicions? So this is kind of routine, but I thought it was interesting to actually go through the steps that the doctor has to go through to gain an impression of how much work is being done that maybe we're all not completely aware of. So first things first, the clinical suspicion and initial workup. So the consultant will take a detailed history. This is the point where they're going to say, tell me what's going on. And a lot of people are saying, even this week, are saying, why do they ask me to relate what's wrong with me over and over again every time I meet a new doctor? Well, I guess this is part of it. They need a detailed history. They quite often don't get much time at all to read through your notes, and lots of you have very extensive notes. So the way to get things done quickly is ask you to explain it. But I guess coming up, if you just at that point present them with a written description of what the situation is, then maybe that would speed things up for both of you. Perform a physical examination and review imaging. So are there any scans available? And then order all the tests that we're all familiar with, blood tests. Precipitins are now getting to be quite an old test, but they're still valid for CPA. You can test your sputum. If you're having trouble producing sputum, Phil the physio will come along here and help you produce sputum, and they have a very good success rate at doing that. Galactomannan is a fungal specific thing to look for, and then the more general lung function tests and chest CTs. So that's the first meeting. Then they have to think about a diagnosis. The consultant will assess whether signs point out to ABPA, CPA. It's very unusual to actually be sat in a consultant's surgery and him having to worry about, is it ABPA, is it CPA, or is it invasive? Invasive disease is something you see in acute disease in emergency care generally. Or someone that you know has massively reduced immune systems, such as someone who's had a bone marrow transplant a week or so beforehand. So we can usually discount invasive disease. Somebody earlier on said that they had invasive disease, and that may be true in someone with CF. But quite often what happens is the doctor seeing you will call it invasive disease because CPA used to be referred to as semi-invasive. I prefer to make it clearer by saying there's acute invasive, which is a rapidly progressing disease that you'll see in chronic clinics, in acute clinics. CPA is something that's very slow growing, occurs in people whose bodies and immune systems are fighting back very efficiently. The fungus can only grow very slowly, so it's not really invading in such. It's chronic sort of erosion type thing. So it's, you wouldn't mix those two up, and you certainly wouldn't mix ABPA up. Though it is possible, as we know, to have ABPA and CPA at the same time in about, I think it was 5 or 10% of cases. In complex or uncertain cases, now most of you will be quite complex because you'll have lots of things going on in your lungs and maybe elsewhere. They may be they may think it's worthwhile, instead of just then thinking about all the possible outcomes, let's take it to a case where we involve the whole team at a multidisciplinary team meeting, so that maybe 4 or 5 consultants can all look at the case, and you can come to a group decision in a complex case as to what the diagnosis could be. This is particularly likely that this will happen if, for example, the CT imaging is not conclusive. There is a coexisting lung disease going on, as with, say, for example, CF, bronchiectasis, COPD, sarcoidosis, all these things, TB, can also be going on in there as well. And if it's something like TB, then the medication you use to treat TB clashes with the medication that you use to treat CPA. So it becomes much more complex, and you might need people with more than one type of expertise to best manage that patient. And if there is a risk of immunosuppression, so you might bring an immunologist in on the discussion at that stage. So you can see how it becomes very complex. It's dealt with, it wouldn't be dealt with in front of you. Normally what you would say at the first clinical meeting, they would say, well, we've had a look at this. I don't know, some doctors might say, I have to talk to my team to figure it out. Others might say, well, I think it might be this, but I've got to check. And that's why you will get a delayed decision, is because they're not sure, the evidence isn't sure, and they have to go to an MDT. Here at NAC, oh yes, there you go. Here at NAC, we actually offer anybody, any consultant in the UK working for the NHS can come and join in our MDT. So if they've got a case that they're not sure of, everybody in that location isn't sure of, they'd like someone who has specialist expertise at aspergillosis, then they can join our MDT, and we do it via Teams usually to make it easy to attend. And that has become a really very popular service that we run now, and covering most of the UK now. People are dialing requests for different types of help from us remotely. So that's been very successful. Then this is what we do. If additional expertise is needed, this is what I've just been talking about, advice and guidance. So this is the first level, is the consultant can send out a request saying, well, I think it's this, but I'm not quite sure, can you advise? Or they can refer the patient to a specialist service like NAC, or the other specialist service units around the country. We're the only one that specialises exclusively in aspergillosis. But there is expertise in London, there is expertise in Cambridge, in Aberdeen, in Nottingham, in Bristol. They will probably deal with most of their patients themselves, but some of them that get too complex, they might refer the patient directly to us, and that's where we get the majority of our patients from. You've already been seen by your local specialist. It's too complicated for them. They don't feel they've got the right levels of expertise to deal with aspergillosis or a potential case of aspergillosis, and they refer on to NAC as a tertiary service, and that's what we're here for. Or severe cases, they can admit them, which we do occasionally. Like we said before, it's not very common in a chronic disease. I've known a few, when Professor Denning used to be here, there were a few examples of cases where he admitted someone who was turned up in quite a bad way with CPA. They were on loads of steroids because they'd been asthmatic, and the doctors had quite rightly been treating asthma with inhalers and oral steroids, and it still wasn't working. And what David did, I remember, was take them off all steroids and treat them with an antifungal medication. And to do that, it was an IV medication, so we had to admit them. So that occasionally happens with chronic forms of aspergillosis, but most often, if the patient is in a bad way, suspected acute invasive, they would be admitted. and all specialists can be engaged. We also advise and get calls about invasive aspergillosis occasionally, but normally what happens is the people who are likely to get these are the transplant people, the people treating cancer, and they're quite used to seeing cases because they're relatively common in cancer to see an invasive aspergillosis case. You'll also remember, I don't know if I'll talk about this later, but you'll also remember it took some time, but people eventually realised people who were in intensive care with COVID infections were being treated for COVID with antivirals, being treated for bacterial infections, and they were still not doing well, and it was eventually realised that they had an aspergillosis infection. I think it was about 3% of people who ended up in intensive care with COVID, invasive aspergillosis was discovered to play some part in their illness. Once that had been recognised and we started to treat for aspergillosis, then their outcomes improved. So, very tricky stuff, and sometimes you've got to think outside the box. This is just formally, the patient should be informed of the provisional diagnosis. This is the sort of thing you'll get in your letter. The test being ordered and why, the potential for long-term antifungal control or monitoring. I mean, we do some of that, but I think the CARES team do more of this sort of information passing on. And any referrals, they should tell you about any referrals that you're about to make. This is just what's in the standard note from your consultant to your GP, or to you if you requested. Did someone want to say something? No? Okay. All steps must be recorded in the patient's record. Formal referral if involving NAC. And of course, they have to share standard NHS data sharing protocols. We can't just send data out as a Word document across the internet because that's not secure. It has to be made so that people can't see it if they manage to intercept something like that. And also, you have to know what data we're holding on you, and you must have the opportunity to change that and look at it and so on. So there's lots of formal steps going on behind the scenes when you attend a hospital here. Okay, and the third question, which kind of relates to the first one, throat irritation and the constant need to clear your throat. Is that related to reflux from bronchiectasis? Now, most people with ABPA will have bronchiectasis, which we cover, which I talk about on the aspergillosis website recently. And the answer is yes, throat irritation and constant throat clearing can be related to reflux. And this is often worsened or linked to bronchiectasis. Bronchiectasis is a widening and a stiffening of your airways. Airways will normally contract down to a diameter which enables you to cough more effectively, but if you've got bronchiectasis, you can't do that, so it becomes harder to cough stuff up. How are they connected? So reflux of more than one type in bronchiectasis. Coughing and altered breathing pressure could promote acid or non-acid reflux. This reflux can reach the throat, irritating the larynx or pharynx, and you will get things like this happening, constant throat clearing, which is, I think was mentioned earlier, hoarseness or voice changes, feeling of a lump in the throat, which I didn't know was called globus, so I've learned something there. Sore throat, especially in the morning, or a dry cough without infection. What do we do about it? Oh, there's more. There are different other mechanisms that could relate reflux to throat clearing. People with bronchiectasis often have a hypersensitive cough reflex, so they cough a lot more than most people. This makes the throat more reactive to minor irritants. And I can talk a little bit about this later if we get there. postnasal drip or environmental triggers, so that can be another cause. Mucus movement upwards, this is what it's supposed to do. The mucus is supposed to travel up your airways and out to clear debris from your lungs. But mucus from lower airways can spill over to the upper airways. That's what it's supposed to do, so I'm not quite sure what they mean by that. Some patients describe the feeling of mucus at the back of the throat, and a lot of people, that will trigger a cough or the need to clear the throat. How to help any of these things? Reflux management, it can be down to your diet, so a dietitian might be able to help. Take the usual Gaviscon antacid. I think that Gaviscon now helps soothing your throat as well. And keep an upright posture after meals. It doesn't give you time for that. I would say an hour or two after your meals, stay upright to stop the reflux happening. Speech and language therapy is very useful to give you techniques for clearing your throat that don't irritate your throat as much. And then nebulized saline or mucolytics that we often come across because of ABPA. ABPA patients tend to produce a lot of quite thick mucus, and mucolytics thin down the mucus so you can cough it up more easily. And if all else fails, go and see a specialist, an ENT specialist, to check for more severe underlying problems. And that was it. That was the three questions, two of which were kind of related to each other that we got. So hopefully that's helped those people a bit. If you've got any questions for next month, let me know on Facebook or in Telegram or anywhere you like, really. All right.
Can I ask a question?
Yeah.
There's a few points I wrote as you were going along. One is about a side effect of inhaled steroids, which even though I use a spacer, I am on rather a strong dose of, it's 250 micrograms, 2 puffs twice a day. So that's a lot, and I use a spacer, and I've still got a horrific geographic tongue, even though I drink water afterwards and try and rinse. My dentist is just, she always refers to my geographic tongue and has the students come in to look at it. 6 to 8 glasses of water a day, that is an incredible amount
That's
of
a lot, isn't it?
water. Yeah, can that include liquid generally, like I do like my coffee?
I think it normally does, doesn't it? Because we're about hydration, and what they're actually saying, if you don't physically drink 8 glasses, because there's a lot of water in your food and other things. So they always seem to sort of make that a little bit vague. So essentially the take-home message is, if you're having problems, drink a bit more, I think.
Right. Okay. I mean, I do quite well, but I don't have a problem. Luckily, I don't have a problem with my voice. But the other 2 points I made were mucolytics. Does that include the drug called carbocysteine?
Yes, I think so.
Right. And on a small point, I was horrified to read on a Facebook group how a consultant had advised, one assumes a lung consultant had advised that the patient couldn't possibly have aspergillosis because that was only something that you might get in the autumn. And so I'd asked if the if your department could send out leaflets to such ignorant consultants for the future. The other point was that fresh air, I think, is a very good idea, to try and get fresh air rather than air conditioning. And so if you're going away, don't use Premier Inns, because Premier Inns now don't allow fresh air. They don't allow you to open the windows, even if the hotel is on the seaside or in the countryside. They would rather use expensive air conditioning. So yes, the geographic tongue is quite an issue for a lot of us, even though we might rinse our mouths out afterwards.
So could you send that question for next month, and I'll research it more thoroughly.
I shall.
Okay, that will probably be the best thing to do.
Okay.
I completely agree about the air conditioning. Air conditioning dries air out, and if you've got sensitive airways, which most of you will have, then dry air is going to irritate. So I think there are ways around that, but they don't spring to mind at the moment. One was wearing a face mask to promote humidity in your chest, I think, or turn off the air conditioning, I suppose. But I can make, especially yesterday, would have made things very uncomfortable. But
Well, exactly. And the hotels don't.
There isn't a perfect answer to that one. I don't know. You might maybe avoid Premier Inn. But,
Yeah. Yeah.
and fresh air is great. Of course, you and I both know there's fresh air and then there's fresh air. So if you're by a road, then it's not particularly fresh. But I get your point that that's perfectly okay, perfectly right. And yes, we are. We do have ongoing programs to educate and suppress and spread awareness around the UK medical community. And we're involved with European Lung Foundation to do it around Europe as well, which in a different program along with Aspergillosis Trust. One of the strategies that we've clearly identified who is not sending us patients in terms of which trusts we don't get questions and referrals from. So we can now target those people and send them information directly in the hope that it will get into the hands of the people that need to read it. Some doctors won't be particularly interested, I don't think, but if we get one or two in each unit, that's probably going to be a good outcome. And there's about 100 hospitals trusts and foundation trusts in the UK that we've not heard from in the last two or 3 years. So it's quite a lot, it's about half. But on the other hand, we're reaching half, which is quite good. So we're trying to improve on that. And that's a big project that's happening. I wrote the plan for it only yesterday. So that will happen. That's going on. Okay, so.
Thank you.
You're welcome. So I've got a feeling I've talked about this before, but just to whiz through quickly. British Lung Foundation essentially merged with Asthma UK to present a website, which is this one called Asthma and Lung UK. They cover all lung diseases and allergy type diseases. It gets 12 million views per year. They do cover aspergillosis, and it's quite nice. I think I originally wrote this, possibly with a bit of help from David Denning, but that would have been back in 2012, 2014, something like that. I think possibly Chris Cosmides helps with it now. So it is good information. It's obviously needs updating regularly, but at the moment that looks like pretty good information. And they also list groups where patients can find support, which our groups were not on, but now they are. We've entered into a formal sort of collaboration agreement with BLF Asthma UK, and they are featuring our patient group, this patient group, all the things that we do on their website. And that should lead to more people becoming aware of what we do, what support we do. Fewer people feeling isolated, which was mentioned earlier, because that's very common for somebody to have aspergillosis and have absolutely no one to talk to about it, which is a dreadful thing to have to go through. There are so many people who are so helpful in these groups. That's a shame. So 12 million people watch this website. Let's hope that we reach out to more people using that link up. And I can probably think of ways to develop that relationship more, and if you have any suggestions, do let me know. The other thing I mentioned earlier on was the European Lung Foundation. They stand up for patients. These are all people. There's Lisa, who does lots and lots of work with Aspergillosis Trust. Most of these people are not professionals. They are patients who are trying to help other patients understand more about their lung disease. They're all different lung diseases are covered throughout Europe. European Lung Foundation is a subsidiary of the biggest European Respiratory Society, the biggest respiratory society in the world. So they have direct links with them, and we are producing, along with Lisa and Aspergillosis Trust, we're looking at projects to try and develop using these people's implement, and as a collaboration together. NAC really only covers the UK, but with these people we can cover across Europe using the same sort of information we do. I don't know if you've ever been to the aspergillosis.org, but on there you can switch to most languages in the world if you want. You can't guarantee that those translations are perfect, because they're almost certainly not. They're automatic translations brought about by Google, but they've improved a lot over the years. So hopefully people will get at least some idea. You too can join in this effort. It's a working group, called PAG, Patients Advisory Group. You can join this group. There's me. There was Jill that used to run the Aspergillosis Trust, and a few other patients. And we all get together once every month or two, and we talk about projects, and we're trying to achieve a number of things, one of which is to support World Aspergillosis Day in February, and another one which is to come up with another meeting which is going to be specific to this group, probably around October time. And I think we're about ready for another meeting next week, actually. Anyone can join if you feel you want to join in and put your opinion in about projects that we could run. You'd be very welcome. If you can go to that website to join, or if not, then get in touch with me and I can point you in the right direction. Or indeed the Aspergillosis Trust. The reasons for being in this PAG: we want to raise awareness of aspergillosis. It's a rare disease. We also want to connect with patients across Europe. We want to improve treatment and care in the future for everybody with aspergillosis diseases. Working together with an organisation like this, which is directly connected to a huge respiratory specialist population, can only have awareness throughout Europe, including the UK. And the fact that this is probably, other than ourselves, this is the only patient-led group in the world working on this subject. And there's the link for how you might want to join the PAG if you want to get involved. It's just a meeting every couple of months, and you can listen to what we've got to say and make any suggestions that come to mind. If you do have a project to suggest, then everything is welcome to the group, and we'll discuss and see how we can do it. ELF have some funds to promote our projects across Europe, so it does work very well. Okay, so probably the last thing I'll talk about today. I don't know how many of you are familiar with the INCAS trial. This is the major trial that we're running here now, which started, well, formally I think it started about last summer. It's only really got running since the new year, in the sense that we're actually recruiting patients right now. Maybe recruiting 1 or 2 patients a month to this trial. I just thought it worthwhile telling you a little bit more about it. If we do approach you when you come to clinic, which might happen, then you'll at least know what they're talking about when they're asking you to join this trial. And anyone else who watches this video, I hope will also be informed. We're talking about this because the poll that we did on Facebook a few weeks back showed us that one of the major reasons that people don't join trials is they don't understand what the trial is trying to do. So this is an explanation of what our biggest current trial is trying to do in the hope to improve the number of patients that come through. Right, INCAS trial. You may have noticed that these acronyms appearing relating to trials. Almost every clinical trial in the country at the moment has one of these acronyms. And the reason for that is you're asked to produce these acronyms by the funding body. So our trial is actually called the Interferon Gamma for Non-Cystic Fibrosis Chronic Pulmonary Aspergillosis Study, which is in short to INCAS. It's a clinical research study employing the role of interferon gamma. I'll tell you what that is shortly. In improving outcomes for people with CPA specifically. So this is not ABPA, this is for CPA. CPA is a progressive lung infection caused by Aspergillus mold. It typically affects people with pre-existing lung diseases such as COPD or tuberculosis. CPA causes gradual lung damage by forming cavities and bleeding, as we found earlier. It leads to repeated infections and can significantly reduce quality of life. Its symptoms and scans are often non-specific, and by that we mean you can mistake CPA for TB for years before you realise you've actually got to, you should actually be treating CPA and not tuberculosis. The way you find that out is you've got a case of tuberculosis, you treat it with tuberculosis medication, and the symptoms don't reduce, or maybe they do reduce a bit, but they don't go away. And what we actually find is then when you treat it for aspergillosis, then the symptoms improve dramatically. We used to say if you don't treat CPA with antifungal medication, then the outcome is usually slow deterioration. If you do treat it, we can at the very least 80% of the time, at the very least, stop the deterioration, and about 30% of the time we can actually start improving patients' clinical well-being. So yeah, I've just said that. It's about 3,500 people in the UK live with CPA. We currently see, probably have seen in the last few years, 1,000 to 1,500. Other places probably seeing a few hundred. So maybe we could creep up to half that number that are actually in the care of hospitals, but the rest are not. We can only presume are not getting appropriate care, and that is why we do our work on awareness to try and reach out to those missing people. 5-year mortality rate may be as high as 40%, but of course, if you're being treated, it's better than that. Currently, CPA relies on antifungal drugs. Treatment relies on antifungal drugs, which most of you will know. You're quite often on those drugs for the long term. We look at giving drug holidays, but we will be returning to antifungal drugs when appropriate, inevitably at some point in the future. Sometimes it's lifelong. We have patients who've been on an antifungal medication pretty much continuously for well over 30 years, which are ex-patients of Professor Demings, because he started looking at these cases in the 1990s, the early 1990s. However, and this works quite well, we have problems with infections becoming resistant to our antifungal drugs, and that's a problem because only one class of oral antifungal drug is licensed, the azole class. They all work in kind of similar ways. They all have similar side effects, although as we go along, side effects are slightly better. So posaconazole side effects are not quite as bad as voriconazole side effects. They're costly, although now they're coming out of license or exclusivity license, the cost is falling, although they're still hundreds of pounds for a course of something like voriconazole. They're not a cure, they're limited effectiveness. What we need, around 6% of patients respond well. What we need is another way to treat CPA, so that when the azole drugs become less useful, we have an alternative for you to go on to. Why doesn't it help everyone? We don't fully understand why the treatment fails. These antifungal drugs, the fungus is completely susceptible for the majority of the time. So why isn't it an antifungal drug that you're taking by mouth working all the time? One theory is that some patients have a weakened immune response. So there is a little vulnerability there. We've often speculated that CPA patients will say, is there something wrong with my immune system? Is that why I have CPA and everybody else doesn't, who's lived under the same circumstance? And it could be. We're starting to see signs of this, and I'll go into that a little bit more in a minute. We're detecting signs of that your immune system works a slightly different way. It's very subtle. It is slightly weaker against fungal infection. And one of those differences is down to something called interferon gamma. Interferon gamma is produced by your body. It's important for fighting infections, fungal infections in particular, like Aspergillus and also all the others. And you're not producing enough of it. Low levels are produced. Here is the paper. Which one is this? This is the original paper. Yes. So what David Denning did a long time ago now, this is 2020, written in 2020, and Chris Cosmidis, the current director, and there's Chris Harris, who we all used to come into these clinics, and Gemma works as a consultant down in Exeter. There are some patients, a few patients, who had got to the point where no azole antifungal drug was going to help. And David came up with this alternative, or experimental alternative, to try and give those people some treatment to improve their situation. The paper looked at interferon gamma replacement as salvage therapy. The way it did it was it looked back on all our patients that had been given gamma interferon. So there weren't loads of them. I think it was about 20. Yeah, 20 people who happened to have been given gamma interferon treatment for something while they were being treated for aspergillosis by us. And what they discovered was those patients visited hospital, had acute exacerbations nearly three times, twice as much, twice or half as often as someone who wasn't on gamma interferon. So here's a hint, a strong hint, that there is benefit to people being given interferon gamma. There is another strand to this, which I think is on the next slide. But what this essentially, patients who were given interferon gamma, quite a small trial, a small number of people, had fewer disease flares and fewer hospital admissions. Now that's very good news.
Can I just say, I was one of those people.
I wondered if you might claim credit for that. You should have been mentioned in this paper, Doug.
I know, I should be there somewhere.
So that's the original one. So just a quick summary. What is gamma interferon? It's a natural protein made by the body, like I said. It helps the immune system fight infections. It was discovered in the 1960s. In fact, I remember it being on the news, the sciencey news. I was a sciencey person even back then. During research into how the body defends itself against viruses and bacteria. And I think this was largely funded as an anti-cancer type thing, because if you can stop viruses attacking us, you can stop some cancers. Scientists found that white blood cells produce different types of interferons, and this was such a difficult thing to do because these things are produced in tiny amounts. They interfere with infections. Interferon gamma, there were several of them, there's interferon alpha, beta, and so on, but interferon gamma was identified as a key type that activates more important immune cells, like these are the things that eat Aspergillus in your body and stop it infecting us, and T cells are the things that will produce antibodies that will help inactivate infection, fungal infection. It acts like a messenger. It tells infection fighting cells to wake up and attack. It's like an army bugler, and all the soldiers are asleep in the morning. In the people with CPAs, research suggests their bodies may not produce enough interferon gamma. That might explain why the infection keeps coming back once they've been cleared of the infection. It comes back because you are vulnerable to fungal infection because you don't make enough interferon gamma. Quite often you're not vulnerable to things like viruses and bacteria because there's enough for those, but fungi seem to need more to protect us. So if you supplement the amount of interferon gamma that's produced by a patient, it gives the immune system a boost to fight the fungus and fungal infections more effectively. It helps antifungal medications work better, so you would use them alongside each other if you could. Reduces flow of lung damage and possibly shortens the length of treatment and reduces relapses. The approach has already shown early promise in small studies, including ours, and is already used in the NHS because interferon gamma is used to treat CGD, chronic granulomatous disease, which is characterized by a person with CGD gets infections. They're not raging infections, but they don't clear the infections, so they end up with granulomatous foci. What they are just your body's desperately trying to clear the infection, but they haven't quite got enough oomph to get rid of the infection, and you end up with a sort of a collection of cells, or swelling, if you like. And it can be life-saving in CGD. So we've got good inpatient information that shows that it can be successfully used to treat infections in another group of people. So we know it's what dosage to use it. We know it's safe. We know it can be very effective. We know its cost. It's not cheap, but we can do pretty good risk-benefit calculations to justify the NHS buying it, and indeed the NHS does buy it to treat CGD patients. That's a pretty rare disorder, so there's not many of those, but there's certainly enough to justify the NHS buying some of this stuff. This is the paper I've just talked about. It's been used to treat small numbers of aspergillosis patients for several years. Seems to be beneficial, but we need to do a properly controlled trial on our population of interest. So we want to know whether we know it works all right with CGD, but we want to know how will it now work just as well on CPA, and that's what this trial is setting out to do. How might it help? Well, this was the all-important paper that justifies this current trial. In 2022, so only, date must be under there, there it is. Only 2 years later, we published this. This is Chris and David and the other Chris. And the important thing about this is, if this is true, then we have to show that patients with CPA are generally producing less interferon gamma than patients without CPA. And that's exactly what this paper shows. On average, this has been kind of done in vitro. When you stimulate the cells of a patient with CPA to produce immunoglobulin, interferon gamma, they produce 312 picograms per ml. Whereas if you do the same experiment on cells of people who don't have CPA, control cells, then they produce nearly 1,000 picograms per ml. So people with CPA don't produce enough interferon gamma, and that paper proved it. So now we can say, all right, then let's do this trial we want to do. We've got 3 papers, all pointing in the same direction, and we applied for funds, and we were granted the funds for an initial trial, which is what the INCUS trial is. We know the proposed treatment is safe and acceptable. We know in an observational study, and the observational study wasn't enough because an observational study is the weakest type of trial. There was evidence of benefit. We had good evidence that patients cannot produce, CPA patients cannot produce enough interferon gamma, which is pointing in the right direction. And we also know that those with defective interferon gamma production tend to get worse outcomes than those who do. So there would have been a whole series of different levels, and we can check how well they're doing using the clinical records. We now have all we need to apply for funding. That's what we did. And we were granted that funding probably 2 years ago now, probably in the middle of the pandemic. We've had to wait to start the trial. Oh yes, for people who might be watching this afterwards, I actually wrote a page on all the different types of clinical trials and how powerful some are in relation to others. We're trying to push up the strength of the trial. The first type was a weak type. If we go through to the next type, it's a much stronger type, and that's when we get the right. If we get the right result, then the NHS will start to go, well, this is a good trial now. This is a more powerful trial. Let's look at trying to provide this on NHS funding. The INCUS trial is a randomised controlled study. Okay, so it's not a double-blind study. And we can see that in a minute. And it's also kind of smaller than a full trial, so it's less powerful. But it is the next step. You don't want to spend loads and loads of money on a full-scale double-blind randomised trial if it's not going to work. So you prepare the way with these smaller trials in the hope of not wasting money. This is running now. People coming into, our patients coming into our clinic who are appropriate to go into the trial are being identified and recruited. If you're not coming into our clinic, then you can ask your local consultant if he thinks that he or she thinks you might be eligible to join this trial. And all of the information is out there on the internet for them to be able to tell. And I'm sure we'd be quite happy to take patients from who aren't our patients from elsewhere in the UK. We need people who are starting antifungal treatment. They're randomly assigned to one of 2 groups. Half will get the interferon gamma and half of them won't. Now, of course, it's very easy to know if you're getting interferon gamma because it's given by an injection. So the people who are getting it will know that they're getting it, and the people who are not will know they're not getting it. This is what makes it a slightly weaker study, because if you know, there tends to be a bias towards saying, oh yes, that new medication made me feel great, and if you don't get it, then you tend to go the opposite. So you can exaggerate the results. That's why this isn't powerful enough on its own to convince the NHS to fund. Each group has 25 people, so now I'm getting a little bit bigger. And we'll assess more things. It's not just things like hospital admissions. We'll look at lung cavities, because at the moment all of these patients are here, so we've got all of their drug record information, all of their quality of life scores. We can study how well they tolerate interferon gamma, because that's obviously an important thing. You're giving it to more patients with different diseases. Do they tolerate it as well as CGD patients do? And how many patients are willing to take part and complete treatment? That's actually running now. The more patients we get, the better. I think there's plenty of. It will run for another 18 months, if I remember rightly. So we're looking at 2 or 3 patients a month. And you might find us appealing to other centres if we're starting to think that we're not going to get enough. Because if we don't get enough, the trial becomes weaker, and we need these numbers to be high. Generally, we approach the patient. Patients who approach, well, we don't accept referrals directly from patients, it must come from your consultant, because they have to assess whether you are appropriate for the trial by looking at all the criteria and the exclusion criteria. The whole point of this effort, and this will take up until, I think it's September next year, then analyse the information, we'll come to some sort of conclusion, write the paper. We will then be able to say to a funding body, right, we've got really nice results, all the information, all the evidence is there. Will you fund us to do a full-scale, double-blind trial? And at that point, we are in a serious situation where gamma immunoglobulins could interfere on gamma, could be produced as it could be funded as a regular NHS treatment for CPA. So if you are asked to participate, please give it some serious thought. Thousands of CPA patients